Welcome, audience. Before I introducing the speaker today, there are some housekeeping items that I need to go over. Broadcasting, we are broadcasting live via live stream and YouTube. Please use the microphone to ask any questions. The recording is always available for viewing. Consider subscribing to our YouTube channel to get notification with videos when videos are added. Sorry. For our viewers, if you'd like to submit a question, text the Bakey or to 37607. You may also submit questions via the live stream feed. Find the video on livestream.com/hmh.edu. We have two more conferences scheduled for 2023. Open aortic training, which will be October 26, 27. And transcranial Doppler imaging and vascular ultrasound masterclass in December 2nd. And now I just want to welcome our grand speaker today. This is Dr. Mike Ackerman. Michael Ackerman is the Windland Smith Rice Cardiovascular Genomic Research Professor and Professor of Medicine, Pediatrics, and Pharmacology at the Mayo Clinic in Rochester, Minnesota. Dr. Ackerman received his MD and PhD from the Mayo Clinic, Alix School of Medicine, and the Mayo Clinic Graduate School of Biomedical Sciences. He did his residency and fellowship training in pediatric and pediatric cardiology at the Mayo Clinic School of Graduate Medical Education. Currently, he serves as director of Mayo Clinic Windland Smith Rice Genetic Heart Rhythm Clinic and Windland Smith Rice Sudden Death Genomic Laboratory. I hope I'm saying everything right. He has published over 650 peer-reviewed articles. Dr. Ackerman has also served as the president of the Sudden Arrhythmia Death Syndromes SADS Foundation since 2006. In 2015, he received the Mayo Clinic Distinguished Clinician Award. In 2018, he received the Mayo Clinic Distinguished Pediatric Investigator Award and the Distinguished Scientist Award from the Heart Rhythm Society. In 2021, he received the Mayo Clinic Distinguished Investigator Award. Dr. Ackerman is an inspiring lecturer and teacher, and I have had the honor to have him as my mentor supporter since 2020, when I rounded with him at Mayo Clinic for a few months, until this day with our monthly meetings. Dr. Ackerman will discuss with us the state of genomic testing for sudden cardiac death, predisposing cardiomyopathy and channelopathy. Welcome, Dr. Ackerman.
Thank you, Adi, and good morning, everyone. And what a treat it is to get to be here and to do live grand rounds. I think this is my first one since the mask came off at our institution. And last week I did one with Vivek Reddy in Mount Sinai, but that was virtually, and it just doesn't do the same. There's no way last week came close to matching the dinner last night and the environment and the fellowship and new friends. And AK or Akanibi, if you're out there, give the front desk the signal that you woke up and showed up, but made a new friend. And congratulations to AK. Some of you may or may not know he did the first ablation in Nigeria last week in Africa, the first one ever. And so it was wonderful to hear about that story and to meet him and the other individuals who spent their evening with me. And I'm delighted to spend my morning with you all. So thanks for having me. I really appreciate this invite. It's been a privilege to mentor Adi. This is live, isn't it? So it could get circulated, then I'll get in trouble for saying this, but I'll say it anyway. She's one of my favorites. And it was very special when she was with us in Rochester, Minnesota. Her father made for me and my wife a homemade shofar, which is one of our family's most treasured gifts, and it was a treasured gift then. In this time that we're in now, it takes on a whole new next level of emotional intensity and meaning. So Adi, thank you. I hope you're going to enjoy this topic as much as I do. We'll do about 40 minutes of monologue and then have a conversation together as we look at the state of genetic testing for the sudden death predisposing genetic heart diseases, or the GHDs. I'm conflicted. These are those relationships with industry. I don't think they will negatively affect our ability to do this well together, but you can be judge and jury as to whether I'm conflicted, and if so, write me up, but I'm not. And we'll try to recognize the phenotypes of these channelopathies and cardiomyopathies just to set the stage for assessing what are those currently available genetic tests, what's their role, how do we evaluate their yield and role, and then probably most importantly, if I can give you the basis to understand how do we incorporate genetic testing into our practice and understand what they are, which is a probabilistic test. And we should be good as cardiologists with probabilistic tests, but somehow we've set up genetic testing with this exceptionalism, as it ought to be binary, yes, no. And when it's not performing that way, we say, this testing is terrible. Well, it's just kind of a testing that joins, ultrasound assessment of hypertropiculations. That's yes or no, isn't it? No, it's probabilistic. And we should, of all people, cardiologists, be good with signal to noise kind of thinking. And that's what I want to help us do with genetic testing. If you didn't know, we've been in genomic medicine for 2 decades now. And 20 years ago, officially, this was declared one of the greatest feats of exploration in history, an inward voyage of discovery. Mark that year, 2003, because that same year, as we'll see in a little bit, somebody whispered in the wilderness that it also might be an outward voyage of chaos and confusion. And we'll see how are we doing now in terms of discovery and enlightenment versus chaos and confusion. Well, those discoveries did bring in genetic testing for all sorts of diseases all across pediatrics, medicine, and in our world of cardiology, so much so that some of us have declared that there is a new specialty in cardiology. You may not know of it yet. It's called genetic cardiology. And there's a new subspecialist in cardiology, and he and she is called a genetic cardiologist. I don't call myself a pediatric cardiologist, and those who practice genomic, genetic-minded cardiology and see patients principally with genetic heart diseases, you ought to start referring to yourself as a genetic cardiologist. And we will look at the role of genetics for the issue of sudden cardiac death. We've had guidance. The guidance is quite new, isn't it? This was 2011, the first ever guidance for what is the state of genetic testing. We've added that in terms of how does that help us in risk stratification and treatment. And the most recent guidance was published last year. And probably the most significant change from the first one to the last one, or the most recent one, is I moved from the chair to et. So I moved my way to the et in the 2022, and we can discuss the reasons for that. But I got over it. But the more important point is the bottom line of those guidelines, then and now, is that if you suspect the presence of a cardiomyopathy or channelopathy in your patient, genetic testing is indicated, full stop. Not optional, not, who needs that? And I'm going to show you why you and our patient and their family need it. And so what we're going to leave here this morning is, if I do this well, you should be able to leave grounded with answers to these 3 questions. What is the test, the genetic test, impact across the triad of medicine, diagnostic, prognostic, therapeutic? What is that test yield? And what is that test problem? What is its Achilles heel, its noise? And I don't know what you think, Dr. Zogby, but I was taught by my mentor, Jamil Tajik, Rick Nishimura, that what separated the true cardiologists, the wise cardiologists, was those who were acutely aware of the dark side of the test that they were considering to do, that had a keen insight into that test noise. And those who appreciated that were much, much wiser interpreters of a test result. And that's so true, and perhaps even more true in genetics. Well, to set the stage, let's take care of a family together. And this is a family that I've had the honor of caring for. It's not their picture. I just lifted this from Good Housekeeping because it was too tragic to use their own picture, because the family story started in tragedy when Chase, the oldest child at age 8, died suddenly in Sunday school, of all places. And here's the reason. Our medical examiner could give you and me the why. This is Chase's heart. So we know why Chase died, didn't we? What's her disease? Hypertrophic cardiomyopathy. What would this family get as the most important next test in a talk about the state of genetic testing? No, but thank you. I wanted you to do that. The family got an echo. And to a genetic cardiologist, do you know what an echo is? It's a functional genomics assay, because we're looking for phenotypic expressivity. And revealed by that echo was, no doubt about it, autosomal dominant hypertrophic cardiomyopathy. Father, clear-cut non-obstructive HCM, never a symptom during his life, triple sport university level athlete. Baby brother at 18 months of age had an 18 millimeter wall thickness. The other two, age 10 and 9 or so, normal echoes. The baby brother at 18 months of age, mom rescues him at age 2, toddling out of the bathtub with an external defibrillator shock. Gets a defibrillator, and then from age 2 to age 6, he has 12 VF terminating ICD shocks. And then I meet him, and I tell the family, time to wave the white flag of surrender, let's move to transplant. That recommendation was too little too late, because 2 weeks after that first evaluation at Mayo Clinic, he died during episode number 13. So now the family has been cut in half, and they come to you and me with a fundamental question that only genetics can answer, and that is, how sure are you that our 2 living children whose echoes are normal don't have it? And it is the disease causative variant, and we would discover it 20 years ago. A single nucleotide substitution resulting in a single amino acid substitution, otherwise known as a missense variant, leucine 185 to arginine in the gene that builds the protein alpha-tropomyosin, as the cause. And we could then do what the guidelines would catch up with later for this family and answer their question. So guidelines take a while to catch up with. A class 1 recommendation, proceed with variant-specific genetic testing in the appropriate relatives. And we did that, and we could answer the mother's question. Her echoes are normal. Why? Well, 1, she's young. 2, she doesn't have it. She is genotype negative and phenotype negative. She is dismissed. On the other hand, he is genotype positive. He's currently echo negative at age 10, so some of us would call him what? A pre-hypertroph. Will he convert to echocardiographic expressivity? Don't know, time will tell. But at that stage, guess what the mother and father, but the mother, had us do for her 10-year-old mutation positive LV wall thickness normal son? She did. And back then, you know what we said? We said, well, what? We don't do that. We don't even know your son has HCM. The only reason we know anything is he has a positive genetic test result. She says, yeah, I don't care. We've already lost 2 of our children. And so we have learned as genetic cardiologists that mothers are almost always right. And you should know that too, in terms of that beautiful thing called just maternal instinct and drive. But anyway, not to say that we should change guidelines, not suggesting that at all, but to illustrate, he is now 30, and guess how many ICD shocks he has had? 5. And with his first ICD shock for VF occurring while his echo was still normal. Now that's just not to shift the guidelines at all, but to illustrate the power of the genetic test. The only reason he's alive is the genetic test result that enabled us to have enlightenment as to who does and who does not have genetic vulnerability for the family's autosomal dominant disease. And in this case, that is in the realm of the cardiomyopathies, a wonderful collection of diseases. And you might have your favorite. Among these, my favorite is hypertrophic cardiomyopathy. And we're going to think about the impact across the triad for this disease of the sarcomere, where these are those HCM causative genes, the major ones, and these genes build the sarcomeric proteins of the heart, and it allows us to call these patients sarcomeric HCM. But then there are these genes. These are those genes that encode the so-called cytoskeletal elements, the Z-discs, the scaffolding proteins. And some of you are old enough to remember that great Ginsu knife commercial. Do anybody remember that? Yeah, but wait, there's more. That's the tagline of that commercial. And there's more in HCM. These are These would be the HCM, some would call them the metabolic mimickers or the HCM phenocopy, Danon disease, Fabry's, and so on. And then these genes that encode calcium handling proteins that would allow us to subset some patients with calcium mishandling mediated HCM. But from a practical purpose, you need to know these. And really what a cardiologist should be familiar with is the two biggies. The one at 12 o'clock, MYBPC3 HOCM, myosin binding protein C, and the one at 1 o'clock, MYH7 HCM beta myosin heavy chain. And why do you need to know those? Not just for what it told us about the rest of the family, who has it, who doesn't, but you need to know it for your patient. Why? Because your patient in front of you, where you're not wrestling with the diagnosis, it is different. Their story is different based upon, do they have a positive genetic test or a negative genetic test? How so? In every parameter we've looked at, those who are sarcomeric HCM, positive genetic test HCM, it's a different disease. They present younger, they present thicker, there's more family history. Of course, it's a genetic disease. And they were more apt to have a defibrillator as a surrogate of the assessed proarrhythmic potential. In addition, across time, compared to those with a negative genetic test, those with a positive genetic test progress towards end-stage disease. These are different diseases. They all get called HCM. The obstructives might meet the myectomy reduction, the septal reduction therapist, but they're different diseases. And in fact, the positive genetic test was the strongest predictor of progression. And it's not just Mayo Clinic saying that. We now have data from the SHARE registry that has said the exact same thing. The SHARE registry, multi-institution, about 5,000 patients. And see that? In every parameter, those who are sarcomeric positive, otherwise known a positive genetic test, are different than those who have a negative genetic test. We have to think about these diseases differently, and because of the impact across the triad, then and now, the guidelines are straightforward. We can do literacy, we can read. It basically says, if you're going to call them HCM, genetic testing is indicated. Pause, shift to illustrate some thoughts with the channelopathies. Now this is my first love. I love HCM, but mainly that was because I mentioned to you the person who hired me was Dr. Jamil Tajik. Dr. Tajik said, Michael, I know you love long QT, but you will love HOCM. And like somebody who would sit in front of Dr. Zogby, you would say, yes, I will. And it turned out that that recommendation created this beautiful understanding where we have probably published as many papers on HCM as we have on long QT, and so allowed some really interesting cross-pollination of the two fields. So he was right, yet again. And if you're listening, Dr. Tajik, thank you, because this is YouTube Live. And here, but long QT is my first love, and let me illustrate some points across that. The first question we have to answer, what's the impact across the triad? So long QT syndrome is the most common of the channelopathies, about 1 in 2,000 individuals. Very challenging because they may or may not give you exhibit A, QT prolongation. Half don't. They may or may not ever give you exhibit B, torsades. 3/4 of my patients have never done that yet. And so risk stratification is challenging for this entity. We've come a long way since it was born, cardiac channelopathies. This field was birthed by Dr. Mark Keating in 1995 when he discovered and published in Cell the cause. The cause being mutations in the pore-forming alpha subunits of the critical ion channels of the heart, like the voltage-gated potassium channel shown here. And those discoveries, loss of function to potassium channels, leaky sodium channels, then set the stage where that ushered in a decade of research-based genetic testing. Some of you participated in that decade and remember it disaffectionately as the black hole, the time and place where samples went and nothing came back. And it took a while, like all tests, to evolve from a research-based effort to clinically available genetic testing, which we're approaching the 20th year. Available clinically, new problem, denied. And then that changed. The landscape of insurance reimbursement and viewing genetic testing as clinically indicated, not investigational. So now we have it available, increasingly covered, and that brought us into our current predicament of available, price point no longer $5,000 like it was in 2004, now $200 or less, and available to the community of cardiologists. So available and increasingly utilized by clueless users. And that's our dilemma, is that are we capable of doing and incorporating genetic testing wisely into our practice when we care for these patients? Lots of disease-causative genes. 10% of long QT syndrome remains genetically elusive. That has implications. It's the highest yield genetic test we have of all of our sudden death genetic heart diseases. But the big three is what a clinician ought to get to know because they account for the lion's share of that 90%, as in about 85 of that 90%. And they have their stories. There's genotype-dependent risk factors. There's genotype-dependent responsivity to therapy. It's one of the few diseases that we uniquely do genotype-directed tailoring of therapy, don't we? Maybe the one disease that gets close to that in genetic heart diseases are the aortopathies, where we call in the aortopathy surgeon 5 millimeters sooner based upon genotype. Okay, but here we uniquely tailor therapy. And we've moved from genotype-directed risk stratification, genotype tailoring of therapy, a long time ago now to intragenic risk stratification, meaning it's not enough to say, I'm taking care of a patient this afternoon with LQT2. The next question would be, what kind of LQT2 are you seeing? We do intragenic risk stratification because not all mutations are the same. These are they stemmed across stem to stern with the LQT2 potassium channel. And those mutations that localize to the channel's pore, you're going to like this one, they behave more, poorly. So they do. The risk is higher than those that localize elsewhere in the channel. And the guidelines made it very clear that because of that impact across the triad, if you can read, genetic testing is recommended. And that's what we said in 2011, that's what we said in 2022. So when it comes to the answer to the first question, what is the impact of the genetic test across the triad for the various genetic heart diseases? The correct answer is, it depends. It depends on what disease are we talking about. The impact is not the same for all, and that's okay. What we need to know is, what is that impact so we are informed. For the cardiomyopathies, it's greatest in HCM, and now probably in the therapeutic category, it probably deserves 2 points, 2 pluses, maybe 3 pluses. The first patient with myosin-binding protein C mediated HCM just received his AAV9 gene therapy last week. So you can't do gene therapy unless you know their genotype. And so it is happening. Gene therapy for these genetic heart diseases is in motion. It is greatest, that is the genetic test for long QT syndrome as I illustrated, and it is changing. You can see 10 years ago, DCM genetic testing was kind of meh, not really worth it, completely different now in 2022 for the why to do the genetic test. So yes, it depends, the impact, but the take-home point for part one is if you or I diagnose a patient with a genetic cardiomyopathy or channelopathy, but we do not pursue genetic testing, we are not practicing contemporary cardiology. So we're working on a white paper statement called Get With the Guidelines, because the utilization and the use of genetic testing for these diseases ranges from terrible to pitiful. I mean, we're just not using it as we ought to, those families who deserve it. Now, maybe that's a good thing, because I don't necessarily want this cardiologist to use genetic testing. Who's this cardiologist? Well, he says, will you screen my patient to see if he or she has one of those bad thingamabobs, or whatchamacallits, so that I know whether or not to implant a defibrillator. Well, maybe it's a good thing that he's not ordering the test then, because that's somebody who doesn't know what does that genetic test result do for me, or more importantly, do for my patients. Because in HCM, there's almost no examples, very, very few, where the presence of that by itself, notwithstanding the case that I shared with you to drive home the point to begin with, but that result in isolation should result in that. Almost never, and it's taken us 20 years to say this over and over again to get the installers to stand down. And maybe it's not the installer's fault, it's the HCM doctor who's sending them there. And so we still have work to do to better understand the role and what it does do for us and what it doesn't. Part one, the longest part. The second question that you need to leave with knowing the answer to, or how to find the answer, is what is that test yield? Meaning, in other words, you know your patient has said disease. What's the likelihood that the current generation genetic test will give me the answer? Because we, of all people, should not be surprised if a test comes back negative. What? It's negative? You mean your 3 centimeter hypertroph doesn't have HCM? No, that's not what it means. So knowing the yield of the test can be helpful, like in the cardiomyopathies, and let me ask you, you tell me the answer. Your patient has HCM. You're not wrestling with the diagnosis. You know it's HCM. You're going to bill it as HCM. You might send it to your septal myectomy person or some septal reduction therapist. What's the yield that the HCM genetic test will come back positive? You can go ahead and give a shout out if you want.
Familial or non-familial?
No, you can't.
Okay, well, you don't get nuanced yet.
Exactly, can't.
Yeah, the beauty of this, the way I set it up, is you could say any of these, and except for number 5, you're right.
75.
Because it depends on what are we talking about with HCM. Like you're getting at is what kind of HCM are we really getting at? All comers, you could just throw, that's 50%. You'd be close. ARVC 45%, that'd be pretty decent. DCM old, 20% was the going rate. But let's take a closer look at HCM. At Mayo Clinic, over 1,000 patients diagnosed with HCM by people who actually really know HCM. Tajik, Nishimura, Amen, Gersh, he knows everything about everything. So they know this disease. They're not wrong with this disease. 38% is the correct answer. But that's not the answer I want you to leave with, because now you will have the ability, with knowing the answers to 5 phenotypic questions, as to what the yield would be. In other words, which hypertroph are we talking about? This one? About half of our patients have sigmoidal HCM anatomically. Or this one? About a third of our patients have reverse curve HCM. Now, if you order the HCM spell checker for the HCM on the left, it almost never comes back positive. If you order it for the HCMer on the right, it usually comes back positive. And in fact, that observation led to something that we called echo-guided genetic testing. The anatomy, the image, the echo guides your and my pre-genetic test anticipation as to whether we're dealing with sarcomeric-driven HCM or not. And we brought that into clinical practice, and the shape of the heart is still the strongest predictor of will my genetic test come back positive. But we can do better than that, and we've done that. And this is in a lot of HCM centers now. It's called the Mayo Clinic HCM Genotype Predictor Score. So based upon your patient in front of you, when your nurse, your PA, your fellow, whoever sets up for the patient and says, you're going to see this patient diagnosed at this age, 23 versus 63, wall thickness 25 versus 18, family history there, yes or no, and what's the shape of the heart, and what's the blood pressure. If you know those answers, now the range, the yield of the genetic test ranges from that. So who is this? So who is that person? Well, he was diagnosed at age 20, wall thickness 25. We elicited family history of disease and death. The heart is reverse curve, blood pressure is normal. That hypertroph has an 80% yield when you subject him to genetic testing. On the other hand, who is she? We have a lot of them. She was diagnosed with her HCM at age 65. Her wall thickness is 18 millimeters. She's got that basal bulge. There's no family history. You can ask about family history as many times as you can think of, and it's called not there. The shape of the heart is not reverse curve, and her blood pressure is 145 systolic. She got called HCM. She might even have met our HCM surgeon, Dr. Schaff or Dr. Deraney, to relieve the obstruction. But that hypertroph almost never has a positive genetic test. That's a different disease with different implications for her and her progeny. And then when you realize what the noise is in the system, you then know that this person, positive, highly likely to be true positive. This person almost never comes back positive, and when it does, it's uninterpretable because it's right there in the noise. And that can help you with the genetic test. Remember I said old news, DCM 20%, that changed in one day. And that day was 10 years ago when Cricket Seidman, we had the privilege of joining her in this effort, discovered Titin-mediated DCM. And now the yield of DCM genetic testing is probably closer to 40%. I'm talking about young, non-ischemic, and so forth. On the cardiac channelopathies, what's the yield when you know the diagnosis is there? We already mentioned for long QT, 90%, CPVT, 2/3, Brugada, 10 to 40, and it's really either 10 or 40, depending on a subphenotype. And short QT syndrome, the yield is low, and who cares? There's more papers written about short QT syndrome than people with it, so we don't need to talk that much about short QT syndrome. I do want to illustrate this, though, by knowing the yield, how you and I can become a better phenotyper. And what do I mean by that? Well, here's long QT syndrome. And I told you that the genes explain 90% of the syndrome. So there's a colleague who at our Pediatric and Adult Congenital EP Society, PACES, always comes up to me and says, Michael, guess what? The company tells me that I still have the best record, that of all of the genetic tests I order for long QT, I'm getting a positive test result back 90% of the time. And I shake my head at him and I said, don't brag. Why? He's missing. He's an absolute underutilizer of the test, because the only way you can have a 90% yield is if the only long QT patients you're ordering the test on is, I don't know, somebody who starts swimming, sinks, loop recorder recorded torsades, and upon surfacing their QTC is 500. That's how you get a 90% yield. But a lot of long QT syndrome doesn't come so obvious. On the other hand, there's a colleague who's in a slump. He, and it's he, has ordered the test over and over and over again and is still waiting for that first magical moment of, it came back positive. So what's his problem? He either doesn't have the foggiest clue of what constitutes the phenotype that merits the diagnosis of long QT syndrome, or he's become an early adopter to universal genetic testing. That's how you get a yield called 0. And so what do we do about these individuals? I don't know what your yield should be overall. It depends on your patient mix. But by knowing this, it can help you. You don't want to be over here because that means you have a dull sword. And one of the ways we can deal with the issue of the clueless users is, expose them. So are you curious? I can tell you are. Were you wondering, like, who is that guy? Yeah, I'm going to show you right now. No, I'm not. That wouldn't be nice, would it? But we might need to go more aggressive because we have a lot of clueless users taking place in there, and we're hurting families by that. But the point for us is, how can we use this knowledge to make us better? And here's how. And I do this with my practice. Every time I order the test, I commit myself to what is my certainty of the phenotype. Definite long QT syndrome. And when I say definite, I better be getting 90%. And then I track, it's reasonable, medium, and then no way, no how. I'm the 5th institution to evaluate this family. I don't know why long QT ever got uttered. And I'm using it to move away from the diagnosis. And when I'm saying no way, no how, it better be close to 0%. So imagine how good we could get if you got a report at the end of the year and it said, every time you said definite long QT syndrome, your yield is 33%. That might be informative. That might tell us, wow, what has made me start calling things definite? And I really think it helps you. And I think I'm stealing from another one of my mentors, Dr. David Driscoll in pediatric cardiology, who said, Mike, with your stethoscope, I want you to tell me, is that a pathologic murmur or an innocent murmur before you use the echo? And then the echo can help you tune your ears to the assessment of the noise of the murmur. That same thinking can help us with that. We have need for more education in this. And I've said phenotype is queen. It's the most important to guide you. And if you're not certain of the phenotype, do not go fishing for the genotype. Last few minutes to do part 3, which is, what's the test problem then? And why am I so concerned about some of the reckless use that's occurring with it? And that has to do with this. When we get that back, how sure are we that the X that marks the spot is truly the disease-causative variant? Remember that very first family? And the decision that we made because the brother had it and the sister did not? We better be right. That better be the cause. And if we're not, we can make some big mistakes. In fact, the guidelines have gone so far that says class 3, ongoing clinical screening is not indicated in genotype negative relatives, meaning if your genetic test comes back negative, we can now dismiss you. Well, we better be right about that assignment of that variant's pathogenicity. These things are not as easy as what they seem, and we should listen to that great philosopher, right? With great power comes great responsibility. And we've been pretty sloppy, the community of genomic-minded individuals, because we have a lot of genetic tests available, and until recently, we haven't had an appreciation of what's the noise in the system. That's all changed with things called Genome Aggregation Database or GNOMAD, but in the past, we sort of said noise. There cannot be noise in disease genes. That's why they're called disease genes. That was the thinking 20 years ago, and some of us raised our hands and said, well, who said that? How do we know that irrefutable disease-causative genes can't tolerate genetic variation in them? And that same year, remember 2003? Greatest feat of discovery. That's when we raised our hand and said, this is going to get really, really problematic. And because we did the reverse experiment for the first time. And that reverse experiment 20 years ago was to take blood donors, healthies, and run them through the disease gene spell checkers and see, and we got ridiculed. They were like, why are you wasting sequencing dollars to run normal people through sudden death associated disease genes for diseases that affect 1 in 2,000 humans? You're going to sequence 1,000 healthies? What a waste of time and money. And we said, yeah, we're going to do that because we didn't buy the premise that there might not be genetic variation in those. And it turns out there is. Just to illustrate, look at that. These are the 3 canonical long QT syndrome proteins. And these are the stem to stern putative disease causative variants. And then when you do that reverse experiment and run 1,000 healthy blood donors through those genes, for those genes, this is what you got. So, oh my goodness, that's not good. And we warned that there's a background rate, and 20 years ago we warned, exercise extreme caution when calling mutations. And isn't it interesting to the scientists in the room, the genetic variation in normals, does that look like it's scattered randomly through the proteins? No. It tells you and me that there are territories of real estate that can tolerate change, that have biological flexibility, that may not care whether it's alanine there or valine there. But you put something like proline to leucine somewhere else in the protein and you've got a problem. That seems now obvious to us, right? Because it's the consequence of that spelling error. What did it do to the meaning of the intended sentence that matters? Here's the sodium channel up close and personal. LQT3 mutations that we published. Brugada mutations from a worldwide consortium of 2,000 Brugada patients. And then rare variants in SCN5A in infant death cases, SIDS. See all those? Actually, those aren't SIDS. Those are 1,000 blood donors. So in this room, 2% of us has something really rare in the sodium channel. 2% of us. If we're black, 4% of us do in the sodium channel. Now, 2 or 4% of us don't have a 1 in 20,000 condition called LQT3. So it's the noise that we're going to have to wrestle with, and we've done work, and others have done work, as to how do you assess the probability of pathogenicity. And the take-home point for part 3 is you have to be grounded in a reality that where you are clearly understand that genetic tests are not binary tests. They're not yes or no tests. Some are obvious disease-causing mutations you could bet the ranch on. Others are obviously benign. Yeah, they don't even get reported. And then others are very probabilistic in nature, and we call those things the dreaded VUS. So there's noise in the system. So if you order a monster panel genetic test, then with a lot of genes on it, 10% of us will come back with a thingamabob in that panel. And in just the big 4 ion channel genes, 7% of us have a rare thingy in those. So you have to have your a priori clearly established in your mind when you've pursued that genetic test so that you and I can enhance the interpretability of the genetic test. There's noise in the system. And what I want to show you is the consequence of the maybe test result, and then set that up for our conversation. So the maybe test result, it gets cleverly labeled. It used to get called possible deleterious. That drove some of us crazy. Well, which is it? Possible or deleterious? Then it got called, and it still is called, the variant of uncertain significance, VUS. Then it gets called the American College of Medical Genetics Class 3 variant. That's helpful. What I've called it is genetic purgatory. And those who understand the VUS issue and are equipped with the tools to escape purgatory or take that variant and bury it in Dante's Inferno will be a better user, because there are some VUSs that in like that, companies said it's a VUS, I said it's the cause. Easy. And people, I've had colleagues who've rounded with me, they say, wow, that was like magic. How did you do that? That's not magic. It's the power of the phenotype that enables you to do that. So let me illustrate, if you're not convinced of the potential danger or spookiness of the VUS issue, I'm going to close with this case because it shows you exactly the wrong way to do genetic testing and then the right way of doing genetic testing. And I love this one too because it was done with my oldest son. This Arthur Wilda gave me this because he made this because he thought it was so neat. Did it with your firstborn son, who's and guess what? After this experience, guess what he went into? You would think he was set up, right, to be junior? No, psychiatry. So it drove him crazy. So here's the story, real story. Remember I kind of said the he cardiologist and the mistake that he made? Well, I want to be fair and balanced. So this is an example of a she cardiologist, because the mistakes are sex chromosome independent. We're all making them. And so this is it. See it? Here's this family story. Starts in tragedy. And look what the medical examiner told us. Keep that in mind. 430, 17 millimeters, mild fiber disarray, but delivered to the family, this is an inconclusive autopsy. So now the family comes to a cardiologist, and should they do that? Yes. Should the living brother be evaluated for the death of big brother? Yes. What does that evaluation look like? That's a whole nother lecture. It's called Complete Heterogeneity Across the United States. It ranges from barely condolences to ordering every cardiac test you can imagine every 6 months. And so we have a real problem with what is the survivor evaluation? What does that look like? But he got evaluated. And here's his ECG. Can you see that very well? No, I'll make it bigger for you. And you know, I could make it as big as you want. And for this Hispanic family, that ECG is called L normal. And guess what the she cardiologist did? Ordered genetic testing for long QT syndrome. Remember what I said earlier? If you're not certain of the phenotype, don't go fishing for the genotype. But we have this expression in Iowa, from where I'm from, is a blind hog gets an acorn once in a while. It's a highly controversial expression because there's an ongoing debate as to, shouldn't it be a squirrel? You know, is it a blind hog or is it a blind squirrel that gets the acorn? Anyway, that expression says, even if you're clueless, you might find the answer. And look at what happened. It came back positive. In fact, it came back with the company saying, we have found for that patient an LQT1 causative variant. Wow. And so now what could she do for the rest of the family? The guidelines say, Class 1 recommendation, variant-specific cascade testing for the relatives. And yep, it's maternally inherited. And then look at for all these family members who is positive for this alleged LQT1 causative variant. And not only that, look who all else is proud owners of an implantable defibrillator. Every single one of them. Okay, stop, look at this. Remember who's the one person who actually has a true phenotype? It's called the young 13-year-old who actually died. And so we then get involved in the story and we find that he has a blood spot card and we ask the question, does the one who was suddenly and tragically dead own the mutation for which the whole family was charged as guilty for possession? And the answer is, he does not. Okay, well that doesn't explain his death, but at least we saved everybody else from an early LQT1 demise. Well, no, because actually The LQT1 associated potassium channel doesn't even care whether valine's there or isoleucine's there. Okay? So stop, let's have my son Jager do it the right way, and that is, let's do the focus on the decedent. And let's do a molecular autopsy. And let's do a whole exome molecular autopsy where we compare the genetic code of the deceased with the genetic code of his living mother and father. And what do we see emerge? Truth, clarity. Because what did he have? He had a sporadic missense mutation in DES encoded Desmond. Do you remember what that medical examiner noted? 17 millimeter wall, mild fibrosis. He died a tragic Desmondopathy. Him and him alone, because it was a de novo variant. And in fact, this leading scientific journal, Wall Street, picked this up on this upcoming sacred holiday for us in the United States, right? Halloween, and said this whole genetic stuff can be really, really spooky. And they're right if we're not equipped with the tools to handle it the correct way. So let me leave you with 5 take-home points and then see what conversation we can have. First, let's remember that the impact of the genetic test across the triad of medicine is lesion dependent. It depends, and that's okay. Get used to and understand what's the deliverables of the genetic test for your family with HCM, your family who might have CPVT, and know what it does provide and know what it doesn't. Second, if you are going to diagnose somebody with one of these genetic heart diseases, genetic testing is mandatory. Get with the guidelines. It's not an optional feature. Third, realize that the yield of genetic testing is genetic heart disease dependent. Get to know the phenotype. And maybe that concept of what's my batting average will hold your feet to the fire and help you in your adjudication of the test. And then fourth, remember that interpreting a genetic test result is not literacy. It must be decoded. In other words, what do I mean by that? We have set the bar for us low, which is said, as a cardiologist, my interpretation of the genetic test is called, I read the report. That's literacy. That's not interpretation. No more than what we were saying last night, that we ordered an ECG for our patient and we read the report called across the top what it said. That's not interpreting the test. That's literacy. And we need to move ourselves from literacy to fluency and understanding. We need to seek concordance between the genotype and the phenotype and embrace and respect the existence of genetic purgatory. You'll be a far better adjudicator of genetic test results. In other words, we need to be a wise user and an even wiser interpreter of genetic testing and the genetic test results so that we can make wise decisions for these amazing families that you and I have the privilege and honor to care for. In closing, I just want to acknowledge the team that has made our program possible on the clinic side and on the laboratory side, and then especially the various support that we've had, including the very generous support from Wendy's family that have partnered with us to heal the sick and advance the science. So thank you very, very much, and I'd love to see if we can have a little dialogue together and see how this went. Thanks. Yeah, and I'll repeat the question too. If you...
Dr. Ackerman, this was one of the best lecture I've heard on genetics and cardiomyopathies and channelopathies.
Oh.
Thank you so much.
Well, thank you.
I definitely feel I'll go back wiser with this. So what my take is definitely phenotype triumphs. Each has their contribution, the genotype and the phenotype. For the child who got the ICD, if it was 2023 and it wasn't the insistent of her mom of getting an ICD, what would you do now? Especially if the child didn't have a family history or a family history.
Yeah.
in both scenarios?
Right, and I think that's such a good question because the mother was very obviously wise. She knew things that we didn't know. But what did we don't know back then? And we knew then and we know now that unlike long QT syndrome, where family history has 0 forecast value, that's not true in HCM. In HCM, family history is one of the big 3 canonical risk factors. And we recently, and since that death, we showed the data that if your single canonical risk factor is sudden death in the family, that was equipotent as a single risk factor as to whether your personal wall thickness was 3 centimeters or not. So family history is so important in HCM. It's so irrelevant in the channelopathies, which has its own interest. Why? Why does family history not matter in long QT, CPVT, Brugada, but matters a lot in HCM? So would we have respected the strength of family history in a genotype positive, LVH negative owner who's had 2 siblings die? That's still a tough one because that would not be a guideline sanctioned indication because the guideline says before you could install, you actually have to have manifest HCM. So it still would have been not clear, but I think there would have been a reaction from those of us from 20 years ago who said, well, we don't do that, to now saying, there's a lot of strength in that. Yeah.
Dr. Atkins, Dr. Ackerman, I have 2 questions for you, sorry. First is how should we approach the education of the fellows to better expose them to cardiovascular genetics because they are the providers of the future that will be testing and asking themselves these questions. And number 2, for those institutions that are looking into building cardiovascular genetics programs, what's your advice as to the structure and the required resources that are needed to provide the best care to our patients?
Wow, those are good. The education part is, it's starting to happen. American Heart Association has recognized that. In fact, Dr. Andrew Landstrom, who's one of my mentees on staff at Duke, he's been tasked with AHA to help develop a curriculum for increasing our fluency with genetic testing, genetic mindedness, genetic heart disease. So I think there's going to be some resources. We just got approval a month ago to launch the first genetic cardiology fellowship. So, you know, we have fellowships in everything, 4th years, extra years, but now we have a genetic cardiology fellowship that will be having the first fellow summer 2024. So that's slow go, that's one at a time, but I think those will be the strategies. I think in terms of building a cardiovascular, a genetic cardiology effort and a program, you need several key things, right? You need patients. So you have to have a drawing card to give people a reason to come for that said genetic heart disease, because you need a critical mass. So when I started in 2000 on staff, the reason to come to Mayo for long QT syndrome was called 0. And since then, I now take care of 1,800 patients, 1,800 with long QT syndrome alone. And so you need to have a commitment to say, I'm fascinated by genetic cardiology. Who's going to be your physician champion? How is it going to be resourced? There has to be an understanding from leadership that in some ways, a family with genetic heart disease is profoundly time consuming. These are not quickies. These are, my standard new patient family consult is 90 minutes to 2 hours. Easy. Don't generate a lot of RVUs. So if Tajik were to have held me to some sort of metric, so you're not really doing much. But there's an appreciation of the need and the vision for genetic cardiology to take care of families with that and not have it set up in some sort of comparator. Now it turns out that having said that, my margin, I'm told, is one of the highest in our Department of Cardiovascular Medicine because almost every patient I see is called not Medicare. And so maybe it is I don't care if it's honestly profitable or not because I'm not tasked with that charge. I'm tasked with meeting the needs of patients and families who are at risk of dying suddenly from genetic heart diseases. That's my mission. And that's what I hold myself to. And as long as, the administrative, bean counters have felt that it's also justifying my salary and the salary of the team, then I guess we're doing a good job. It's challenging. I mean, there's a lot of elements that you have to put into place, but you have to have a reason for patients to come. And so that means you have to publish. I mean, patients, or you be in a huge population draw where you don't have to publish anything, the families just have no choice because that's the population center. Yeah. Yes, sir.
Thank you so much for coming and sharing with us a difficult topic and so well presented.
Thank you.
And in answering Dr. Duarte's, I think the education starts here. Mm-hmm. So I'm so glad that we have your lecture, on files for people to go back to, because it's very enlightening in a difficult situation that is evolving, no question about it. I have two questions for you. One, regarding the variability of the genotype and its significance, particularly in the long QT, where you have quite a few other conceivably mutations that are not clinically significant. Mm-hmm. Do you see the same in HCM?
Yeah.
Is it that frequent?
Yeah. So in HCM, so in the long QT big 3, there is a 4% background rate of noise. In the HCM big 2, and we could make it the big 5, myosin binding protein C, heavy chain, troponin T, tropomyosin, it's on the order of 5 to 10%. So the difference again, and that's where your variant adjudication comes in, because if you ordered the test on somebody who had an HCM pre-test score based on phenotype of 0 to 1, and now you get a rare variant that the company called VUS in a minor gene, that thing is so stuck as a VUS that you're never going to get it unstuck in short order. On the other hand, you ordered the test on a patient who had the Mayo Clinic genotype predictor score of 5. And you said, I know that brings with it an 80% yield. And now it comes back with a VUS in one of the two most common genes. Myosin binding protein C is going to be 40 of that 80%. Heavy chain is going to be another 40 of that 80%. Well, that MYBPC3 VUS is not stuck because of the owner of that variant. And so that one, you can get it unstuck immediately. And that's the failure right now, and the failure or the opportunity. Because the genetic test companies, how much phenotypic data do they ask for you and I to be able to execute the test? 0. Just imagine, and I've advised them over and over again, start by doing something simple, like a Likert scale. What is your likelihood of disease for the patient that you're ordering it? 5 out of 5, 0. And then that would help, it would actually start helping in variant adjudication. So that patient, you and I could immediately move that MYBPC3 VUS to the cause with high confidence, higher than what their current score requires for it to be called a likely pathogenic or a pathogenic variant designation in the first place. And we've published this under the moniker of phenotype enhanced variant adjudication. But there's all kinds of challenges with that. Who's the phenotyper? So a company, you can imagine, they're challenged because what level of credit or stock do they assign to that in-house assessment? So even me, I used to, I don't even bother wasting my energy anymore and say, just to let you know, I have taken your KCNH2 variant that you called a VUS, and like that, I'm prosecuting the family as the cause for long QT syndrome. They say, thank you, bye. So we're not closing the loop to make variant adjudication a learning exercise, and I think that brings with it a lot of opportunity.
The other question I have for you is a disease that you have not addressed and your thoughts on it, which is Barlow disease in the young individual with sudden cardiac death.
Yeah.
And the question to you is, what's the role of genetics there? We ascribe quite a bit of the arrhythmias and issues to some fibrosis in the areas. And the question, is this the causative thing, or is there something genetic?
Yeah.
that is predisposing, and would you do any genetic testing?
Yeah. So Barlow's or mitral valve prolapse, and we took a lot of heat because obviously the vast majority of mitral valve prolapse, as you know better than me, 1 to 2% single leaflet prolapse is a nothing. But we've argued, but there's got to be a sliver of the sudden arrhythmic form of prolapse. So not all prolapse is equal. And we advanced that with a discovery from our lab in 2014 where we described the new syndrome of arrhythmogenic bileaflet mitral valve prolapse syndrome. And that syndrome was unearthed from starting to see a lot of sudden cardiac arrest survivors all coming to me, and you can imagine what referral diagnosis they came with, long QT syndrome. And we started to do their phenotype and endophenotype and realized there's no long QT here, but there is this combination of I am woman with funny looking T and U waves with bileaflet mitral valve prolapse, and then later we would describe mitral annular disjunction. And so out of that came this sliver of malignant mitral valve prolapse. And then, so there is this sliver, and I think that sliver is arrhythmogenic bileaflet mitral valve prolapse syndrome. Now, it turns out you don't have to be bileaflet, but most are for this entity. And then the question is this a non-genetic entity, a monogenetic entity, a polygenetic entity? And the answer is yes, all of those. Monogenetic mediated is really rare. We published a couple of case examples of arrhythmogenic bileaflet mitral valve prolapse syndrome due to filament C, FLNC. But that might be sort of one of those coexistence of an FLNC cardiomyopathy superimposed with a structural bileaflet mitral valve prolapse. So that's where I think this entity of arrhythmic mitral valve prolapse syndrome, typically bileaflet, is going to turn out to be not very monogenetic at all. The yield is super low. And so you have to recognize that because that means a VUS in a super low monogenetic disease process is practically speaking going to never be the cause. It'll be a VUS, as the companies are now saying, VUS leaning benign. So now we have two new additions. It's VUS leaning to the left and a VUS leaning to the right. And these would be very benign leaning, ambiguous variants. But a couple of hits, but only a couple. It's been a little too much money for a little too low of a yield. Well, thank you very much, and now on to our RVU generating day. So have a wonderful day. Thanks, everyone.